The biggest challenge in AML until recently has been treatment of older adults with AML, and that's the population over the age of about 60, and that's actually the vast majority of adults with AML. The problem has been that only a subset of these patients could tolerate the cytotoxic regimens based on cytarabine and anthracycline, and even those who tolerated it didn't have long-term leukemia-free survival. So the progress has been limited in what we call older or elderly AML, but the introduction of venetoclax-based regimens has changed this because now we have effective strategies that are also relatively non-toxic, and this, in my opinion, will dramatically change the picture in older AML therapy. In the younger patients, we've also been fairly stuck at a ceiling of long-term survival, and the advances in that population has been identification of subsets with genetic abnormalities that are susceptible to specific therapies, and the approval of FLT3 inhibitors, midostaurin and gilteritinib, and potentially in the near future quizartinib, will help FLT3 mutated patients at least to some extent, and the approval of IDH1 and IDH2 inhibitors and axitinib and ivosidenib is also benefiting the IDH mutated population at least to some extent.